So today we're going to talk to you about low-frequency ultrasound versus negative pressure wound therapy for chronic venous insufficiency.
So here we have our PICO question laid out for everyone. Our PICO question was, in patients with chronic venous ulcers, which adjunctive therapy yields a higher healing rate? Non-contact low-frequency ultrasound or negative pressure wound therapy?
Our patient case is of a 78-year-old male named Tom who has been suffering from chronic venous insufficiency for 5 years. He's a retired postal worker who now enjoys stamp collecting and light gardening. He lives in a 2-story row home with his wife, both of which are smokers of over 25 years. The patient has a past medical history significant for diabetes, hypertension, and obesity with a BMI of 31. Patient ambulates short distances in the house using a rolling walker, and all other mobility is via his wheelchair. The patient presents to physical therapy with an irregular shaped wound on his right medial lower leg after hitting his leg on his wheelchair 1 week ago. The leg is warm to the touch with a weak but palpable pulse, and the wound is producing copious drainage. The wound is partial thickness with beefy red granular tissue. Here we have Tom's ICF chart with his health conditions being his chronic venous insufficiency, diabetes, and hypertension. Tom's body function and structure impairments would be his venous wound on his right medial leg, his decreased lower extremity strength and decreased endurance. Activity limitations due to these body function and structure impairments would be inability to ambulate over 10 feet, inability to navigate stairs, and inability to complete his hygiene and grooming tasks. Tom's participation restrictions include no longer being able to garden, he's unable to assist his wife with household chores, and he's unable to participate in social events with his neighbors. Some environmental factors for Tom: a negative would be his challenging home setup, being that he lives in a 2-story row home. There are stairs that he has to navigate. A positive would be his family support from his wife. Personal factors for Tom: he has poor healing ability, he's obese, and he also has a history of smoking, which would all be negative personal factors.
Here are the risk factors for chronic venous insufficiency. They include trauma and surgery, especially to the lower leg, obstruction, varicose veins, a hemorrhage or hematoma, phlebitis, DVT, and obesity, just like our patient Tom. Along with obesity, Tom is also older, but also genetics, multiple pregnancies, smoking, ankle immobility, standing for a prolonged time, and congestive heart failure can all cause venous insufficiency. So chronic venous wounds form due to venous hypertension. In the lower extremity, the calf pump will fail due to muscular weakness, impaired range of motion, or incompetent valves. This will cause the pressure in the veins to rise. After this pressure rises, backflow occurs, which causes venous congestion and edema. This edema can lead to ulcerations due to the inadequate circulation to the skin and subcutaneous tissue. Here are some key signs and symptoms for chronic venous wounds. Your patient will experience a dull, aching pain that increases in dependent positions, especially if they've been standing for a very long time. This pain will improve with leg elevation, and these wounds typically occur in the medial aspect of the lower extremity. The wounds typically begin superficially and then progress to full thickness. There's typically moderate to copious drainage. They're irregular in shape. Eschar and will not be present, but slough may be. And there's typically beefy red granulation tissue. And the patients will have a palpable pulse. Here are a lot of statistics about the incidence and prevalence of chronic venous wounds. Overall, the incidence is 76.1 per 100,000 people. Venous leg ulcers are common in elderly patients, yet 22% of individuals can develop their first venous ulcer by the age of 40, and 13% can develop it by 30 years old. The annual prevalence for individuals 65 to 95 years old is 1.69%. Males typically get venous wounds more than females, and upwards of 70% of chronic leg ulcers are related to venous disease, while only about 20% are due to arterial insufficiency. Apart from that, upwards of 3/4 of venous leg ulcers heal after 6 months. But there is a recurrence rate that is 6 to 27%. So even when the best practice pathways are implemented, only 50 to 75% of leg ulcers achieve complete healing after 6 months of treatment. This is where we're going to come in as PTs.
Okay, so non-contact low-frequency ultrasound, which is pictured on the right, normally operates at frequencies lower than normal ultrasound, so around 40 kilohertz. It uses normal saline solution that is vaporized by ultrasound energy. The transducer is held close to the skin surface but not in contact with it, and then slowly moved over the treatment area. It's entirely painless to the patient and has the ability to penetrate up to depths of 3.5 millimeters. Its recommended parameters are continuous mode with 100% duty cycle, a frequency of 40 kilohertz, an intensity of 0.1 to 0.5 watts per centimeter, and 1 minute per centimeter squared. So every centimeter squared of area, you're spending 1 minute with the ultrasound head over that. In terms of precautions and contraindications, breast implants, malignant tumors, pacemakers, and carotid sinuses are all things that you should be aware of. So now for some background information on negative pressure wound therapy. It uses controlled subatmospheric pressure that is applied to open wounds. The primary components consist of the suction device, a wound filler, and an occlusive dressing sheet cover. The theories of how it works are microstrain and macrostrain. Microstrain is occurring at the cellular level, and it's thought to promote cell migration, proliferation, and granulation. Macrostrain is occurring at the tissue level, and it's thought to promote wound edge contraction, removal of bioburden, increased blood flow, and removal of interstitial fluid. Some of the benefits of negative pressure wound therapy include healing moist wounds, increased perfusion, increased granulation, reduction of bacteria, and a reduction in frequency of dressing changes. In terms of the parameters, it's recommended to operate at 50 to 125 pressure, depending on the wound. 125 millimeters of mercury has been found to promote the highest level of granulation, however. It's recommended to be on continuous, intermittent, or variable, depending on what your treatment aims are, and you're recommended to change the dressings every 48 to 72 hours. Precautions include patients who are on anticoagulants, patients who have a low platelet count, and non-enteric or unexplored fistulas. Contraindications include wounds with greater than 30% slough or necrotic tissue, untreated osteomyelitis, and malignancy.
This study looked at 24 individuals with chronic ulcers of the leg due to chronic venous insufficiency. The individuals were split into two groups. Group A received conventional therapy, which consisted of hydrocolloid dressings and compression therapy, whereas Group B received conventional therapy as well as 30 kilohertz ultrasound treatment for 12 weeks. After the 12 weeks, the ulcerated area was measured, and the mean area decreased by 55.4% in the ultrasound group, compared to 16.5% in the conventional therapy group. In this study, MIST therapy was administered 3 times a week for 90 days to 163 patients in addition to standard care, and 47 patients received standard of care only. Standard of care consisted of moist wound healing, daily dressing changes, and debridement. The patients in this study had wounds of various etiologies, but what's pictured here is the results for just the individuals in the study with venous wounds. As you can see, there was a 97% decrease in wound volume with MIST therapy and standard care, compared to a 49% decrease in wound volume with the standard care group alone. This study looked at individuals with chronic venous insufficiency. 13 were placed in a standard of care group, and 13 were placed in a negative pressure wound therapy group, as well as standard of care. The standard of care consisted of compression therapy with short stretch bandages, as well as hydrogel and alginate dressings. The results of the study demonstrated there was a median heal time in the negative pressure wound therapy of 29 days compared to 45 days in the control group who just received standard of care. The study defined heal time as the time from surgical debridement to 100% epithelialization.
So what's the clinical bottom line here? What heals the chronic wound faster between the non-contact low-frequency ultrasound and the negative pressure wound therapy? Based on the 4 studies that we included, we found that the non-contact low-frequency ultrasound would be best to yield a higher healing rate as an adjunctive therapy compared to negative pressure wound therapy. This was particularly true with the MIST therapy. The study that we had incorporating the MIST therapy saw faster healing rates compared to the standard care, as well as a 97% decrease in wound volume, which was compared to a 49% decrease in wound volume for standard care. The study also had good results for venous wounds specifically, and it had a very large sample size, which was not necessarily true for the negative pressure wound therapy studies. But overall, with both of these, for the non-contact low-frequency ultrasound and the negative pressure wound therapy, more research needs to be done. Particularly randomized controlled trials that compare the non-contact low-frequency ultrasound to the negative pressure wound therapy would be beneficial. And comparing both of these to other standard cares that would increase the amount of research to produce quality systematic reviews of the literature would also be beneficial.
Okay, so now we're going to tie in our patient case to everything that we just discussed. So now Tom has been in the hospital for 2 weeks and his wound has failed to close due to his poor wound healing ability caused by a combination of his previous comorbidities, his history of smoking, and non-optimal blood flow to the area with an ABI of 0.7. His leg has taken on a champagne bottle shape and his edema has become more brawny and fibrotic. Induration is now visible around the peri-wound, and there are signs of infection with 35% slough and purulent exudate. The wound has 65% granular tissue, and there is evidence of epithelialization around the wound edges. Due to Tom's current presentation, we chose to go with a non-contact ultrasound, the MIST, instead of the negative pressure wound therapy. The MIST is a better choice for Tom because the mechanical stress caused by MIST ultrasound energy results in bacterial cell death and reduction of bacterial count. Even with very difficult strains of bacteria, it is still effective. The MIST also disturbs biofilms, which can cause the wound to stall in its healing. These two factors together can stimulate vascular endothelial growth factor in the wound bed that causes angiogenesis and mediates blood vessel growth that accelerates the wound healing. And this will allow Tom to have a shorter hospitalization and a faster return to function. Our plan of care for our patient first starts with evaluating their blood flow to help determine their ability to heal the wound. The patient had an ABI of 0.7, which is going to require a modified compression with a pressure between 20 and 40. For debridement and modalities, we chose the non-contact low-frequency ultrasound for all the reasons that were previously discussed. Because the patient has a venous wound with copious drainage, we want to choose a dressing that has high absorbency, like an alginate or a foam. These two dressings also facilitate autolytic debridement and protect from contaminants, which is good because the patient has a high potential for infection. As for all patients with venous wounds, edema management is a big part of their treatment. So compression therapy, we chose a multi-layer short stretch compression due to its high working pressure and low resting pressure so that when the leg is elevated, the vessels will not be occluded. We want to educate our patient, of course, teaching him about modifiable risk factors such as obesity, smoking, and inactivity, and promoting the importance of his adherence to his compression therapy. Because we're a physical therapist, of course, we're going to promote exercise. We want to improve the calf pump to get the blood flowing back up to the heart and reduce edema in the leg. We want to increase ambulation and overall activity and promote elevation of the leg.
So as a physical therapist, what do we need to pay attention to here? First off, both non-contact low-frequency ultrasound and negative pressure wound therapy are adjunctive therapies. Therefore, this means that this is not a replacement for care such as sharp debridement or surgical excision. Also, it's important to note that both these adjunctive treatment types have been shown to increase healing rate and lead to a greater decrease in wound volume compared to the standard care alone. So when we use both of these, when we're looking at the non-contact low-frequency ultrasound, we want to do this 2 to 3 times per week for approximately 6 weeks. And this is based on a Medicare policy. We should also use this for venous wounds that are not progressing more than 30 days. Use this for painful chronic venous wounds. And it should be used if sharp or surgical debridement are not possible. Negative pressure wound therapy, we're going to keep it on for 48 to 72 hours, and it's not something that needs to be changed every day. Again, like the non-contact low-frequency ultrasound, it's going to be used for a venous wound that isn't progressing. It's also good for maintaining a moist wound and removing exudate. It's good for loose slough, but not for hard eschar. Good for reducing edema, and it's very good for increasing granulation tissue.
So just a quick summary to tie everything together. Non-contact low-frequency ultrasound did appear to be better for yielding wound healing in chronic venous ulcers. However, with that being said, there is a lack of research in regards to direct comparisons between non-contact low-frequency ultrasound and negative pressure wound therapy. So that makes it difficult to definitively say whether one is better than the other. However, examining the studies we used and comparing outcome measures between the different studies, we came to the conclusion as a group that non-contact low-frequency ultrasound was the superior modality in this instance. With that being said, both modalities did appear to be effective in terms of healing chronic venous wounds, and you should always keep in mind that neither modality should be used alone. They should be used to supplement other forms of care. So just because one modality had a really good outcome, you shouldn't be ditching your standard of care in this circumstance.